And we're back. Ladies and gentlemen, it's time to hear from our next speaker. We've had questions from virtual participants. Now it's time for an actual virtual speaker at the 2023 Smith-Lemli-Opitz syndrome. It's a good thing that we all learned how to speak Zoom over the last few years, don't you think? It means we're just ready to jump right in. Our next speaker is Dr. Shika Sundaram. She's a pediatric gastroenterologist in Aurora, Colorado, and she's affiliated with multiple hospitals in the area, including UC Health, University of Colorado Hospital, and Children's Hospital, Colorado. She received her medical degree from University of Kentucky College of Medicine and has been in practice for more than 20 years. Dr. Sundaram is here to talk about SLOS, gastrointestinal symptoms, and treatment. Dr. Sundaram, welcome.
Thank you so much for having me in this virtual space. I appreciate it. I'm just going to bring my slides up. So I appreciate the invitation and the opportunity to join you all virtually. I'm going to talk about the GI manifestations of Smith-Lemli-Opitz. And again, my hope is that you'll understand sort of broadly the GI manifestations, but also understands potential treatment options to be considered. I think as Dr. Elias said just a few minutes ago, each patient is an individual, and so treatment plans have to be individualized, but I'll try to provide some broad strokes. Not surprising to this audience, I think we all understand that SLO is an autosomal recessive condition that has a very broad phenotype. Certainly that applies to the GI manifestations of this disease as well, and is due to a deficiency in cholesterol synthesis that's caused by abnormally low activity in the 3-beta hydroxysteroid D7 reductase. And as a result of that, in the end, patients have low cholesterol. Dr. Elias started to touch on this, and I think there was some discussion at the end of the last talk about feeding difficulties. And I think that this is probably one of the most challenging things that many patients with SLO and their families experience. The symptoms can be broad and start often in the neonatal period because babies with SLO have low tone or hypotonia. They may have a poor or abnormal suck, and as a result of that, may also have difficulties with swallowing. They may have vomiting because they have small stomachs or microgastria. They may have intestinal dysmotility, or in other words, their intestine doesn't contract as it should, and reflux symptoms, all of which can lead to a lack of interest in foods that is further complicated by oromotor discoordination or dysfunction. Again, I think as Dr. Elias mentioned, the muscles that help you suck and swallow are not too different from those that allow you to verbalize. As neonates turn into infants, they sometimes develop some oral tactile defensiveness, if you will, probably because they've experienced some poor experiences with foods. As a result of that, may have some difficulty progressing to more textured or chunky foods. That is further complicated by the fact that some patients with SLO have milk and soy protein allergy in addition to other food allergies. We also know that statistically, infants and children who have more severe congenital anomalies are more likely to have more feeding problems. And so what do we do about this? First of all, it has to be recognized, and that comes from a good history and a good physical exam, which in my eyes includes a weight or a length or height, and also a head circumference. Head circumference is often the most unreliable measurement just because it can be difficult to take. And if we're seeing persistence of feeding difficulties that result in difficulty to grow, both weight and or length, in addition to the dietary manipulations that have been mentioned by previous speakers, other things that can be tried include gavage feeds. So essentially a tube that goes from food into the stomach, typically through the nose, and it can land in the stomach. As shown in this picture here, that would be a nasogastric tube. Some patients require an NJ or nasojejunal tube feed. And so that basically means that the tube is much longer, sneaks through the stomach, through the first part of the intestine or the duodenum and into the jejunum. And this allows for less vomiting and less reflux. The problem with doing jejunal feeds is that the jejunum is not suited for bolus feeds or large amounts. And so patients who require jejunal feeds have to have a constant drip or infusion. It's not always comfortable in the long term to have a tube dangling out of your nose. And so in patients in which feeding tubes will be required for longer, can actually have a gastrostomy tube placed directly into their stomach. It's actually a relatively easy procedure. Kind of looks like a pop top or a Tupperware container on the outside, and a similar thing can be placed where the tube goes from the stomach into the jejunum, and we call those GJ tubes. So therapeutically, these can be good options to help get in the amount of volume necessary for growth, and also sometimes to make some of the foods required more palatable. As I mentioned in the previous slide, milk protein allergy, soy protein allergy, and food allergies are more common in patients who have Smith-Lemli-Opitz. And so particularly in neonates and in infants, a trial of hypoallergenic or elemental formula is certainly a reasonable thing to do to see if feeding difficulties actually get better and growth improves because the underlying problem may in fact be food allergy. And then this came up in the Q&A. Another thing that's really important is for patients to have who are having feeding difficulties a very thorough oromotor or feeding evaluation that can then inform what the problems might be and therefore what the right therapies might be beyond getting calories in by tube. I kind of think about feeding difficulties and failure to thrive or failure to grow as going hand in hand, obviously. And we know that infants who have Smith-Lemli-Opitz tend to be small for gestational age or small at birth and grow below the 3rd percentile even when they are getting adequate calories. And what I'm showing you on the right-hand side is a growth chart specifically for patients who have SLO, and it's plotted against the Center for Disease Control or CDC growth curve. So the SLO patients are in the solid red, blue, and black lines, and then the CDC growth curves are the hashed tag lines. And so what you can see is that in general, in the first 3 years of life, patients with SLO, given appropriate calories, will grow, as you can see by these solid lines, and they kind of grow on their own curve, but it's important for us as pediatricians, as gastroenterologists, and also as families to understand that their growth is going to be different than children who are unaffected, and really pulling up these growth curves to help us understand how they're progressing can be quite helpful. I did not know previous to starting to prepare for this talk, but it has been pretty well described that patients with Smith-Lemli-Opitz also seem to have a problem with hypermetabolism in the first 3 years of life. And so they may require up to 200 calories per kilo per day just to maintain their body weight. And to level set for you, that is 2 to 2.25 times more number of calories than we would expect for a child that was of the same age who was not affected by Smith-Lemli-Opitz. And clinically, in addition to poor growth, these patients may have warm skin and a little bit of tachycardia, but otherwise seem to be healthy and in the context of their primary disease. And I put these growth curves up just to give you a sense of what this looks like. So On the left-hand side, on this top part is weight for 0 to 3-year-olds, and on the bottom is height for 0 to 3-year-olds. And so the weight curves, which I've already showed you, are similar to the height growth curves that you might see. Again, height looks pretty similar to other patients initially, and then starts to peter off, but these kids do continue to grow. And what is really interesting when you look at these growth curves is that as they get older and past age 3, while they still are smaller, their growth velocities and growth curves start to match up more with children who are unaffected by SLO or the typical CDC growth curves. And that's probably because of interventions in their nutrition. I don't think that I really need to touch on this because the previous speakers have talked quite a bit about cholesterol, but there have certainly been observational studies that have demonstrated the benefits of cholesterol in many spaces, but certainly in growth and weight gain, but also in pubertal development. And we know that puberty happens for a lot of reasons, but you're unlikely to go through puberty if you're malnourished. So I'm going to switch gears now and talk about reflux. And we use reflux as a very broad term. It's common in infancy. It does seem to improve with age in some individuals. And so as gastroenterologists, when we talk about reflux, we really talk about it in 3 different spaces. One is just gastroesophageal reflux, and that is the passage of gastric or stomach contents into the esophagus with or without regurgitation or vomiting. So those gastric contents may come up into the esophagus, and they may or may not come all the way out, if you will. Gastroesophageal reflux disease, or D, sometimes called GERD, is when the reflux really starts to become troublesome in terms of symptoms or complications, such as esophagitis, which is inflammation of the esophagus, which can lead to stricturing or even poor weight gain. And then refractory GERD is GERD that is not responding to treatment after 8 weeks, which from a family's perspective can feel like a really long time. This is a slide borrowed from NASPGHAN, which is our National Pediatric GI Society. And I show this to you to help you understand that spit up happens and reflux happens, and that it happens in children who don't have low tone and are otherwise healthy, and 40% of kids up until they're 3 to 4 months of age. And so that's pretty common. And now we're adding the low tone of Smith-Lemli-Opitz in some babies on top of that, which is going to really increase that number. When you look at the natural history of reflux over the first year of life, it decreases dramatically so that less than 5% of babies at around a year of age are spitting up most of their feedings. I'll be honest to say that I was unable to find any data to help me understand at a year of age, what is this percentage in patients who have SLO? I would expect that it would be significantly higher, but also to continue to go down. The symptoms of reflux are very, very broad, and they can include discomfort or irritability, poor growth and feeding refusal, dystonic neck posturing, or what we sometimes refer to as Sandifer syndrome, where the children kind of throw their head back and arch. Now that can be tricky because that can also just, quote unquote, be behavioral. You may see true vomiting or regurgitation. As kids get older, they may actually complain of heartburn or chest pain or epigastric pain. They may have smelly breath, like dysphagia. Rare to have hematemesis, which is throwing up of blood. And then you can get respiratory symptoms as a result of reflux, including wheezing and stridor and cough and hoarseness. And then you can see dental erosions. You can see irritation of the esophagus in a variety of ways, and true apnea spells, asthma, pneumonia, and even otitis. And Rob Kramer, one of my colleagues here in Colorado, made and shared this slide with me. So how do we diagnose reflux? First and foremost, it's really a clinical diagnosis, so that the signs and symptoms that I mentioned to you, those are ones that we would walk through in a patient that we were seeing in clinic and trying to understand, do they have reflux? And sometimes that's really all we need is a solid clinical history taken by you and taken by our patients. Sometimes we need an upper GI radiography where patients are given oral contrast that outlines the upper GI tract. And the reason we use that is specifically to look for a condition called malrotation, where the intestine is turned about itself, or sometimes stricture. And it really doesn't help us understand reflux versus that is physiologic, because everyone burps up some stuff, versus non-physiologic. You can do esophageal pH monitoring. It's typically for 24 hours. A probe goes from the nose down into the esophagus, and sometimes a dual probe into the stomach, and it detects pH, or how acid balance is the esophagus. The nice thing about pH monitoring is that you can look at episodes and understand the relationship to symptoms. However, it's typically done off of medicines, which some patients will not tolerate. You can't really detect the difference between swallowed contents and reflux contents. And it also doesn't detect reflux that is non-acidic. And so we use it sometimes, typically in sort of refractory cases that don't seem to be responding to therapy. And then last but not least is upper endoscopy, or what sometimes people call a scope, quote unquote. This is really used to determine esophageal damage, and can also help us understand if symptoms are actually not from reflux, but from infection or food allergy. And the biggest downside is that it's an invasive procedure that requires anesthesia, although the anesthesia is usually at about 20 minutes. So how do we treat reflux? That's probably really what matters the most, right? Conservative measures, if you will, are really first line. And so positioning can make all of the difference. And so in little ones, having them more upright or at an angle can really be helpful. And so sometimes people think, well, I'll put my baby in the car seat or in one of those little baby bouncers, and that's great as long as you have them strapped in, because if you don't, what happens is the longer they're in there, the more smushed up they get, and then the positioning is actually the worst thing that you can do. In older patients, you can raise the head of the bed, you can raise the head of the crib. There are actually little wedges that you can buy on Amazon that kind of elevate the whole person. And then in patients who are old enough to, left lateral decubitus position or sleeping left side down actually changes the anatomy and can also help. We recommend for patients who are having reflux that they not eat for about an hour before sleep. And if you can help it, avoiding spicy foods, citrusy foods, or heavy greasy foods. And in the SLO population, the cholesterol and the things that we need to suspend the cholesterol in are often a little bit heavy and greasy. And so this can be tricky. And then the other thing is kind of smaller meals can help. Formula changes. Should we, shouldn't we do formula changes? There is no in general data that hypoallergenic or low allergenic formulas really help the treatment of reflux. The caveats to that is that particularly in neonates and infants, reflux symptoms can look very similar to the symptoms that patients may have a cow or soy milk protein allergy. And so a trial of a hydrolyzed or amino acid-based formula for allergy is reasonable as long as we know that it takes at least 2 weeks for the milk protein to work its way out of the system and to really see things that seem better. So changing formula every 2 or 3 days is probably not going to help. And then last but not least, we have medications in our pocket. We have acid blocking medications that either block the H2 pump or acid blunt or the proton pump within the stomach. We have things like cimetidine and ranitidine and omeprazole and lansoprazole. There are many, many different formulations. Some come as a liquid, some come as a tablet, some come as a sprinkle that you can open up and put into some food. And we certainly can use those in patients in which conservative measures are not working. A key thing to understand is that acid blockade does not stop reflux from occurring. It simply means that the reflux that is occurring is no longer acidic. And that can be very, very disheartening or frustrating to families because they think it's going to stop the stuff from coming up. I think sometimes it stops a little bit of the stuff from coming up because it's less acidic, and therefore the body's natural response is to be able to swallow it down a little bit. But generally, it doesn't help the physiology. It doesn't change GI motility. It doesn't change gastric emptying. And it doesn't change the relaxation of the lower esophageal sphincter, which is the muscle between the lower part of the esophagus and the stomach, that when it's tightened, keeps vomit or reflux from coming up. In the general pediatric population, the data also does not suggest that these medicines necessarily help fussiness or pain symptoms, but maybe improve vomiting and spitting by helping if there's esophageal irritation. So we certainly prescribe them. We just are really honest with families about what they're going to do. And then I would say last, but certainly not least, is what we call the Nissen fundoplication. Sometimes people call it a fundo or a Nissen or a wrap. And I've got a picture of it here, really very, very basic picture of, quote, the normal stomach. And I'm not a surgeon and I don't play one on TV, but essentially what the surgeons do is they take the fundus or the top part of the stomach and they literally wrap it around this lower part of the esophagus, which is the lower esophageal sphincter, so it's tight. The problem with this is that sometimes Nissen slip, not sleep. And so they loosen over time and then symptoms come back. Sometimes they're too tight and then patients experience gas and bloating, which they often say is worse than the reflux and the vomiting. And sometimes they just don't work at all. And so, there are certain very well thought out patients for whom which a Nissen fundoplication actually is a good option. But I think that this is a surgery that we here use very, very sparingly and with great caution. While we're on the upper GI tract, I want to talk about pyloric stenosis. Pyloric stenosis is, or hypertrophy of the pyloric stenosis is statistically more common in children affected by Smith-Lemli-Opitz. The pylorus here is this very last part of the stomach. It's sort of the conduit that closes down between the stomach and the intestine. And in the top of this picture, you can see a healthy pylorus and you can see that it's nice and open and food could go through pretty easily. With hypertrophic pyloric stenosis, you can see that the muscle actually hypertrophies and it's too thick. And as a result of this, the space for passage of food and formula is narrowed. Typically, symptoms include projectile, an impressively projectile, non-bilious, meaning it doesn't look like bile or is yellow-green, vomiting in the first month of life. And the reason that it is non-bilious is because this muscle is so tight that intestinal fluids can't actually get through. And babies often get very dehydrated very quickly and lose weight very, very quickly. A key to diagnosing this is exam. And sometimes you can feel that thickened pyloric muscle in the appropriate area of the abdomen. It sometimes is described as feeling like an olive. In reality, most babies are pretty upset because they feel terrible and their muscles are all contracted and you really can't feel that olive. Blood tests will show some electrolyte abnormalities that are pretty different from other types of vomiting. And then really the best way to diagnose this is abdominal ultrasound, which is pretty easy to do. and it shows that both the length and the thickness of that muscle is abnormal. We sometimes use a contrast or upper GI study, but this is a little bit more involved and is typically not needed. We treat pyloric stenosis first and foremost by IV fluids to help the dehydration, and then treating the abnormal electrolytes. And from there, the surgeons can do what's called a pyloromyotomy, which simplistically means that they just slice open part of that muscle so it's open more. And in patients who do not have Smith-Lemli-Opitz, that usually takes care of it. However, patients who have intestinal motility problems with Smith-Lemli-Opitz may continue to have some symptoms that could be thought of as being related to pyloric stenosis. Constipation is another very, very common problem in patients with SLO. Again, probably primarily related to their low tone and intestinal dysmotility, but I think that the special diets and the cholesterol that they are on may in some way or shape or form contribute to that as well. And I hope you're not still eating your snacks. And if you are, I apologize. We have these fabulous poop pictures in all of our clinic rooms. And really what we're shooting for in terms of a patient not being constipated is shape number 4 that looks like a banana. So it's soft and it's moist. It's kind of, we call it the Goldilocks poop, not too hard, not too soft, just right. And really constipation are these shapes 1, 2, and 3 that look like rabbit poops or lumpy rabbit poops stuck together or a cracked. I hesitate to use the word sausage. 20 years into this field, I don't know why gastroenterologists compare poop to food, but we just can't help ourselves. And then we really don't necessarily want the stools to be down at 5, 6, or 7, where they're sort of runny and ragged and mushy and can really cause a lot of breakdown on the bottom. It's also important to understand what's a normal amount of poop per day. And so this chart shows you that the average number of poops per day in a baby 0 to 3 months of age who is breastfed is 3, and formula fed is 2. But that's a pretty broad range. And if you look at the range of bowel movements per week, it can go from 5 to 40. So everybody doesn't poop every day. And then from there, it goes down about 2 poops per day, 6 to 12 months, 1, 1.5, 1 to 3 years. And after that, a typical bowel movement is about 1 per day, but everybody doesn't go every day. And so how often you go together with what do your poops look like are really important. I hope everyone is familiar with this fabulous book called Everyone Poops. You know, again, as a gastroenterologist, it's one of our favorites. But the truth is that we can, over time, get everybody pooping and pooping appropriately. We really try to start with non-pharmacologic therapies that include increasing fluid intake and trying to get a good amount of fiber in. Our general rule is age of the patient plus 5 grams per day. That can be done with things like benefiber, which is easily mixed into food, or true food. Sometimes pre and probiotics can help. And then as children are toilet trained, a toileting routine can really help with constipation. Potty sitting for 10 to 15 minutes after every meal, and sitting there for, roughly 5 minutes and giving rewards, because that really is going to help kids of any developmental stage understand and take advantage of their gastrocolic reflex. Body mechanics are really really important. And let me just show you a picture. What we don't want is our patients up on the toilet dangling, because what that does is it really changes the mechanics so that your internal and external anal sphincter and the muscle sling, the puborectalis, that need to be lined up to allow for defecation to happen are actually at a pretty acute angle. And so really what we want is for the angle to be different and for patients to be in more of a squatting position. And so for many patients, this actually means that they need a little cheap stool like this little guy has in the bathroom to allow their body to be in more of a squatting position. And then when that doesn't work, we certainly have lots of medications. They fall into some different categories. Osmotic laxatives are ones that draw fluid or water into the colon and are basically just stool softeners. It's all they do. They make the stool softer and make it easier for them to come out. And patients can stay on these for quite some time. We tend to use Miralax a lot because it's really easy to titrate up and down. Some patients need true stimulants. The problem with stimulants is that it causes squeezing, but it also can cause some cramping. But those sometimes are needed to get the process moving. And then we have other stool softeners that can be used like Colace and mineral oil. I really prefer the osmotic laxatives. And then Hirschsprung's disease is sort of a very specific type of constipation. Again, patients affected by Smith-Lemli-Opitz are at increased risk of Hirschsprung's disease, which is a congenital absence of ganglion cells or neuronal cells within the colon. And it can happen in a short segment of the colon, or it can affect the entire colon, which is much, much more rare. On this picture on the right, you can see a diagram of the normal colon. This is kind of the bottom and where the stool would come out. And the intestine is essentially the same size throughout because there are ganglion cells or neural cells here. In areas in which, if you're affected by Hirschsprung's, you don't have ganglion cells, what happens is that the colon in that area is contracted or very, very thin. And then the area behind it, if you will, is dilated or stretched out. And we can actually see this if we do an X-ray, a special kind of X-ray. Symptom-wise, patients may present with perforation of their colon while still in utero. They may have delayed passage of meconium, that thick, black, sticky stool that's at birth. They may develop infection or enterocolitis of their colon, or simply be very, very distended or obstructed. And usually the diagnosis is straightforward, but you may have what we call ultra short segment Hirschsprung's, where it's a little teeny tiny piece that doesn't have neural cells. And as a result of that, everything doesn't work, but it's not so simple in those cases to diagnose. And we diagnose it typically with an unprepped barium enema, meaning we don't give a regular enema beforehand. And again, you can see on this picture, this narrowed area followed by an area that's very dilated. To really confirm this diagnosis, you actually need a full thickness rectal biopsy. So you have to get through the whole series of layers of the rectum to get both sets of neural tissue. And in places in which they have this, we do in Colorado, some patients are diagnosed by anorectal manometry, where a catheter is inserted into the rectum, a balloon is blown up, and then an infusion occurs. And based on the changes in pressure with the different infusions, there are sort of pathognomonic or clear ways that the picture looks. I'm going to skip this. And then I'm going to turn to liver disease, which is really my favorite organ. So what does the liver do? I think it does a lot of things. It synthesizes and stores amino acids, proteins, vitamins, and fats. It acts as a detox house for the body. It regulates blood glucose. It drains bile or liver juice, which is really important to absorb nutrition. And then it's a filter generally from the body. Certainly, patients with Smith-Lemli-Opitz can have liver disease. It impacts somewhere between 2 and 16% of children, and the presentation age is variable, and the severity of presentation is variable. And so some patients may have very mild to moderately elevated liver enzymes or aminotransferases. That would be kind of a mild phenotype. And some patients actually have very severe cholestasis or jaundice. These are patients with the most severe phenotype. Their bilirubins are elevated, but interestingly, another lab test that goes with bilirubin or GGT typically is not. And these patients who have the severe cholestasis may have rapid progression of liver disease that is associated with early mortality. Thankfully, this, I think, is a relatively rare occurrence, but described in the literature. Bile acids are an important thing that the liver takes care of. And so bile acids act as detergents, and they basically help to emulsify fats and help aid in digestion and absorption. And what does it mean to emulsify a fat? Well, I don't know if anyone has ever made like an oil and vinegar dressing at home, and you put your olive oil in and you put your vinegar in, and there are two separate layers, and then you whisk it around really hard or you shake it up, and eventually it emulsifies and it all looks the same. That's what bile acids do for fats within the GI tract. And so bile acids are made from cholesterol, and we don't really need a biochemistry lesson, but cholesterol turns into cholic acid and chenodeoxycholic acid, which are primary bile acids, which are then further changed into other bile acids that are important. So if you're low in cholesterol, that should mean that you would be low in bile acids. And if you're low in bile acids, you're going to have a hard time absorbing your nutrition because you're unable to emulsify your fats. And so this can become a problem for patients with Smith-Lemli-Opitz as well. Interestingly, patients who are more mildly affected seem to have more normal bile acid synthesis. And as a result of that, typically bile acid supplementation is not needed or necessary. There are some patients who have almost complete absence of bile acids, and they may have terrible problems with fat malabsorption and may have terrible problems with absorbing what we call fat-soluble vitamins, vitamin A, D, E, and K. And so that's something that we need to pay attention to, is to make sure that patients don't get deficient in those, because we can obviously supplement those. So when we see patients and are concerned about liver disease, we're looking for stigmata of chronic liver disease that include large organs, big liver or big spleen. We often are looking for, quote, other chronic causes of liver disease before we sort of blame it on SLO. And we will often do a picture using liver ultrasound to see what the liver looks like. Treatment-wise, monitoring is the key thing to keep an eye on what the liver tests are doing. If they've been elevated and there's some evidence that liver labs get better with cholesterol improvement. We sometimes use ursodiol, which is a medicine that helps to stimulate the bile flow or the liver juice flow. If we can avoid in patients who have liver problems other medicines that impact the liver, that's ideal. And then I've mentioned fat-soluble vitamins, cholesterol, and bile acid therapy if needed. So that's what I have, and I am more than happy, if time permits, to take questions. And I see in the
Thank you so much. Are there any questions from folks in the room? Or are there any questions online?
Yes, there are a couple of questions online. Let me get to those real quick. This person says, my 2-year-old son with an and I'm not a medical terminology person, endoscopy was diagnosed with glycogenic acanthosis and with esophagitis LA-A. Should we be worried about that? First of all, do you know what that is? Should we be worried about it, and which medicine should we give them?
Thank you for that question. And it's
You're
never
muted.
fun. Oh, I'm muted? I don't think I am. Can you all not hear me?
We can't hear you yet. One moment.
Okay. Okay, you guys can hear me now? Is that what I'm seeing? Okay. I'm a little embarrassed, quite frankly, to say this to our friend who asked the question. I'm not sure that I know what glycogenic acanthosis and esophagitis is. And so, to be perfectly honest, I don't know that I could tell you with any confidence how concerned you should be about it, nor which medicine would be used to treat it. I assume those diagnoses would have been made by a gastroenterologist. And so I think continuing to interface with that physician probably is a good idea. I'm really sorry, I can't give you more information than that.
Okay, thank you. I'm getting reports that everyone online can hear very well, so the video will have after the conference will have a much better volume level. The next question is, why does SLOS affect feeding and growth?
Why does it? Well, it affects feeding and growth for a few reasons. One of the reasons that affects feeding is because patients have low tone, and therefore they have low tone. Their intestines or GI tract are low motility or don't squeeze quite as much, and therefore may be harder for them to move food through, and also may feel full more often. They may be hypermetabolic for some period of time, and then they probably don't absorb, at least initially, all the nutrition that is going through their body because they're deficient in the detergent, if you will, or bile acid that is needed to sort of mix up the food that is going in and absorb it appropriately. So it's generally not just one thing, but a combination of things.
Thank you. Just a couple more questions. What is the best treatment? What is the best test for and treatment of severely delayed gastric emptying?
Gastric emptying is a really difficult one to sort out. There is a test called a gastric emptying scan. It's a nuclear medicine scan. The hard thing about it in children is that there are not good normative values for kids, and it's particularly bad in little ones. It starts to become better as you approximate adult size or adult age. And so it can be used. We typically think that in order for it to be helpful at all, patients have to be able to take something that would approximate normal food. And so we call it a mixed meal. And it's typically a scrambled egg that has this contrast sort of mixed in it, to see how quickly that scrambled egg that is nuclear medicine attached moves through. And so we can have some sense of it's good, it's bad, but because we don't have great normative values in pediatrics, it's not a perfect test. And then quite frankly, even if we're able to diagnose delayed gastric emptying, it can be a little bit difficult to treat. We years ago had a great medicine that was available to us. It was excellent for delayed motility and delayed gastric emptying. The side effect profile of that was terrible and dangerous. And so it's actually no longer available, at least to us in the United States. So we sometimes will use medicine called erythromycin, which is a common antibiotic. We take advantage of its side effect profile, which is that it causes squeezing of the intestine. If anyone's ever taken erythromycin, it gives most people diarrhea, but it squeezes better. And so that can help with gastric emptying. And then there are some endoscopic procedures that some people do. I don't do them, but where you can actually inject, for example, Botox into areas in the stomach or around the pylorus that can help with gastric emptying. So there's a few things that we have available, but can be a little bit tricky to treat.
Okay, one more last question. This is someone who is older, 42-year-old with SLOS. What about, what are some causes and prevention methods of a sudden diarrhea attack after a regular poop?
I think we'd have to think a little bit about why that was. Often a sudden diarrhea attack is for a few things. One, it's actually not so much that it's diarrhea, but it's what we call overflow encopresis. And so a little bit of poop has come out and now there's some room, and all the loose stool that is in there that is trying to kind of get out can escape around the sides, if you will. And so that might be a possibility. The other thing that we see is sometimes that is related to what the person is eating, and that sometimes high fat foods can cause that sort of sudden diarrhea, or we call it urgency. But that's a little bit unusual. And so that is certainly something where if your family member is having that urgency, you know, if it's every now and again, I guess I would be less concerned. But if it's pretty regular, that's probably something that should be evaluated by a physician to understand, is it overflow encopresis? Is it related to nutrition? Or is there something else going on, like, you know, like some infection, or it could be related again to dysmotility related to their SLO.
Excellent. Well, thank you so much, Dr. Shikha Sundaram, for this helpful information that you've presented to us remotely today. We're so glad that you could join us.
Thank you. I appreciate everyone's time.